She was called the unsinkable ship. At over 880 feet long and weighing 46,000 tons, it was, at the time, the largest movable man-made structure on Earth. But at 11:40 p.m. on the 14th of April, the lookout spotted an iceberg immediately ahead of the Titanic and alerted the bridge. First Officer William Murdoch ordered the ship to be steered around the obstacle and the engines to be put in reverse. It was too late. The starboard side of the Titanic struck the iceberg, creating a series of holes below the waterline. 5 of the ship's watertight compartments were breached, including the number 6 boiler room. It soon became clear that the ship was doomed. Let these exposed high-pressure pipes in the boiler room remind you of our recurring sketchy symbol for the treatment of hypertension. In this sketch, we're going to cover both your usual outpatient treatment of primary hypertension as well as acute management of hypertensive emergencies. But before we reenact this moment in history, I'd like to first focus on some of the first-class amenities provided for, about 96 hours on this one-of-a-kind vacation cruise liner. On board the Titanic, the first-class section had a gymnasium, a squash court, even a Turkish bath, and of course, a swimming pool. It's all happening on the primary deck, and this is where we will depict the first-line drugs used to manage primary hypertension. There is no uniform agreement as to which antihypertensive drugs should be given for initial therapy. The major options are thiazide diuretics, ACE inhibitors, angiotensin II receptor blockers, and calcium channel blockers. Initial monotherapy is successful in many patients with mild primary hypertension. However, patients who start out with blood pressures more than 20/10 millimeters of mercury above goal may need a little extra help. Single drug therapy in these patients is unlikely to attain goal blood pressure, and initial combination therapy using 2 drugs is recommended. Hence, our kindly reminder that 2 life preservers are recommended when aiding fellow passengers who are more than 20 pounds overweight. These can be given as 2 separate agents or as a fixed combination. Some patients have an indication for a specific drug that is unrelated to primary hypertension. For example, a non-dihydropyridine calcium channel blocker or beta blocker for rate control and AFib. That drug they're on is also treating their hypertension. In the absence of a specific indication, remember those 4 main classes of drugs: thiazide diuretics, long-acting calcium channel blockers, ACE inhibitors, and angiotensin II receptor blockers or ARBs. One of the most widely used agents used as initial monotherapy is low-dose hydrochlorothiazide, a diuretic that causes sodium and volume loss at the distal nephron. Well, hydrochlorothiazide will be represented by this kid on the high dive, as he immediately realizes the irony of partaking in a leisurely swim at the very moment the Titanic plunges toward the ocean floor. Take a look at those pasty yet muscular thighs. His chloro speedo, along with those glaring thighs, will be a recurring theme for hydrochlorothiazide. Though commonly used, hydrochlorothiazide may actually be less effective than a related agent, chlorthalidone, which has been shown to reduce cardiovascular events. So just keep that chloro speedo in mind and get accustomed to seeing chlorthalidone on the patient chart instead. Stay tuned for more info on the mechanism of action of these ubiquitous diuretic agents in our hydrochlorothiazide water slide sketch. Alright, each of the first-line antihypertensive agents is pretty much equally effective in lowering blood pressure. However, there is wide interpatient variability as many patients will respond well to one drug but not to another. You will encounter studies and guidelines that suggest that calcium channel blockers and thiazides are more effective in black patients. Unfortunately, they don't provide a scientific definition of who exactly to consider black. They were likely hampered by the fact that there isn't one. You can't actually divide humans into neat categories of race, even though humans try really hard. Luckily, they also have recommendations for specific medications based on objective facts like the presence of certain comorbidities. But ultimately, you and your patient will decide together what treatment is best for them as a unique individual. One traveller here is determined to enjoy the first-class amenities, even as the deck crumbles behind him. Honestly, I'd also want to savour every last bite of that all-you-can-eat calcium from the soft serve machine, our recurring theme for calcium channel blocker therapy. Specifically, long-acting dihydropyridines are most commonly used. These vasodilating agents end with that dipene suffix, so we've incorporated into the sign for the dipene pool. And since thiazide agents can be especially useful in black and elderly patients, he's showing off those unmistakable hydrochlorothiazide thighs, with the matching chloro speedo of course. Another commonly used agent for the treatment of mild primary hypertension is an ACE inhibitor. If you recall, we learned about how this agent interrupts the renin-angiotensin-aldosterone cascade in the April Showers Casino sketch. Well, our ace-stealing, deck-stacking dealers are back, manning the poker tables on deck. Remember too that ARBs, which directly inhibit angiotensin II, are related agents that are also helpful in the initial treatment of hypertension. Many elderly hypertensive patients will have a specific indication for an ACE inhibitor or an ARB, such as heart failure, diabetes, or previous myocardial infarction. So let's sketch in our recurring floppy, sad-looking heart failure balloon, the broken heartstrings myocardial infarction banjo, as well as a sweet and diabetes-inducing candy jar. Just a quick recap of a few clinical settings where ACE inhibitors are first-line therapy for treating concomitant hypertension. The outpatient treatment of primary hypertension usually involves trying to find the simplest drug regimen to which the patient is most responsive, with minimal side effects and maximum adherence. Over time, more than one drug will be needed in many patients who are initially controlled on a single drug regimen. Despite the prevalence of chronic hypertension, hypertensive emergencies are relatively rare. A marked or sudden elevation in blood pressure may be a serious threat to life and requires prompt attention and control. We've sketched in the boiler room attendant rushing over to our recurring sketchy symbol for hypertensive emergency treatment, the emergency shutoff switch. The clinical scenario will go something like this. A 55-year-old man with a history of chronic hypertension arrives at the ER with blurry vision, lung crackles, and pressures of 195 over 115. There are two important components to this question stem. First, increased blood pressure is usually deemed a hypertensive emergency when systolic is over 180 or diastolic is over 120. Let this 180-degree protractor over a 12-inch ruler on a workbench in the boiler room remind you of pressures rising above 180 over 120. Second, our patient is showing acute ongoing signs of end organ damage, which can include blurry vision, lung involvement, or even neurological symptoms. Just look at that 200-foot hole in the Titanic's number 6 boiler room. So, we've got pressures above 180 over 120 and end organ damage. What do we do? Well, there are a few options. It is generally unwise to lower the blood pressure too quickly or by too much. This can cause ischemic damage to areas that have grown accustomed to the higher levels of blood pressure. For most hypertensive emergencies, pressure should be reduced gradually by no more than 20% in the first hour, and then, if stable, to 160 over 100 within the next 2 to 6 hours, and then cautiously to normal during the following 24 to 48 hours. Up on deck, you'll witness the swan song of the members of our beta blocker symphony sketch, the beta 1 buglers. Remember that the rousing bugle represents those heart-activating beta 1 receptors. When muted, they represent beta 1 receptor antagonists such as esmolol and metoprolol. These beta blockers are given IV to rapidly bring blood pressure under control, hence the IV covering the deck of the ship. In fact, all the agents discussed here for hypertensive emergency are given IV in the acute setting. Labetalol is another parenteral beta blocker used in the acute setting. See the alpha and beta labeled stops that our organist uses to modulate flow to the pipes? Labetalol exerts both alpha and beta antagonistic effects, with those extra alpha-1 blocking effects making it a potent vasodilator. Take a look at the smokestack over here at the center of the sketch. It's big, red, and dilated, evoking an image of a ridiculously open, dilated artery. That's because all of these agents we're about to discuss cause potent vasodilation, aiding in the rapid reduction of peripheral resistance, thereby lowering pressure. There are two important consequences of this to keep in mind for exams. First, this significant reduction in peripheral vascular resistance can eventually lead to hypotension, which when sensed by the body triggers a reflexive sympathetic response. This consists of reflexive tachycardia in addition to a reflexive increase in sodium and fluid retention due to direct sympathetic stimulation of renin released by the kidney. See our budding internist aiding a fellow passenger who has collapsed from excessive hypotension? He whips out the old heart-shaped reflex hammer, our recurring sketchy symbol for reflex tachycardia, whilst holding a renin rain umbrella. Whenever you see that big open yellow umbrella, remember that renin is being released, leading to increased sodium and fluid retention. The other important consequence to remember from all this vasodilation is a decrease in the small artery and arteriolar resistance the heart has to push against, and so a decrease in afterload on the heart. Whenever we want to show afterload reduction, we include a scale that reads load. And in this scene, afterload is getting reduced by our passenger here, hastily throwing excess weight overboard. Let's go through a few more of the agents used to decrease afterload and pressure in the setting of hypertensive emergency, each represented by their own emergency lifeboat. First of all, recall from our calcium channel blocker ice cream parlor sketch that certain dihydropyridine calcium channel blockers exert potent vasodilatory effects. Well, our first lifeboat here, definitely not filled to capacity by the way, holds a lady with our recurring symbol for calcium channel blockers, a delicious cup of calcium ice cream of course. Specifically, a couple of the dihydropyridines are most commonly used, administered via IV. Nicardipine, represented by this nice card she's writing, and clovidipine, highlighted by the clover. As she wishes good luck to all those people still on board, remember that these agents cause arteriolar dilation to reduce systemic resistance as evidenced by her red floppy arteriolar sleeves. So let's sketch in our next antihypertensive agent used in the treatment of hypertensive emergency, and also safe for the use in pregnant people, and that's hydralazine. Represented by this hydro boat, a fire rescue vessel sent to aid the passengers. Hydralazine is a direct arteriolar vasodilator with little or no effect on the venous circulation, hence the floppy red arteriolar hose. Here is a pregnant person being helped aboard to remind you that the use of parenteral hydralazine is primarily limited to pregnant people. Notice that we've made Rose over here fainting. Keep in mind that when administering hydralazine, the fall in blood pressure can be sudden and begins within 10 to 30 minutes. This potent vasodilator can precipitate a hypotensive response, resulting in reflex sympathetic stimulation. The ensuing reflexive tachycardia can actually exacerbate angina in patients with coronary artery disease. So let's sketch in our recurring angina anvil, tying down this hydralazine hydroboat. For this reason, a beta blocker is often co-administered with hydralazine in order to blunt this reflexive sympathetic response. Looks like one of our beta blocker band members with his beta 1 bugle packed away is having some major second thoughts about going down with the ship. As he shoves over the doctor about to tend to our light-headed friend over here, let that falling heart-shaped reflex hammer and closed renin umbrella represent those reflexive sympathetic effects that can be minimized by beta blockers. Turns out that reducing afterload on the heart with hydralazine can also be useful when managing heart failure due to systolic dysfunction. So let's sketch in our recurring floppy and failing heart failure balloon. Notice though that it's attached to a stick of dynamite being thrown at a nearby iceberg to make way for the incoming rescue boats. Well, a lit stick of nitroglycerin is our recurring sketchy symbol for nitrates. And we've included it here because hydralazine, when combined with nitrate therapy, has been shown to provide symptomatic and mortality benefit in selected patients with heart failure due to left ventricular systolic dysfunction. Mortality benefit is highlighted as usual by a symbol of a guardian angel preserving life for the souls on board this doomed vessel. The rationale for combined therapy is this. Hydralazine acts as an arteriolar dilator to reduce afterload, while nitrates act as venodilators to reduce preload. When used together, this can reduce cardiac filling pressures. We'll learn more about how nitrates venodilate to reduce preload in our upcoming sketch, The Ballad of John Nitro. One more thing to mention about hydralazine. Hydralazine can also rarely cause a drug-induced lupus-like syndrome manifesting as arthralgias, myalgias, joint swelling, pericarditis and pleuritis, rash and a fever. So we've brought back our lupus wolf helping out with the rescue. There is another nitrate used to manage hypertensive emergency, and that's nitroprusside, represented by the speedboat powered by nitropressure. When administered IV as sodium nitroprusside, this agent causes systemic vasodilation almost immediately. Nitrate vasodilators work by providing nitric oxide, a gas depicted by this nitric oxide exhaust. Nitric oxide works at vascular smooth muscle to induce the generation of cyclic GMP, and whenever we want to convey increased GMP, we bring back the old GMP grump. Remember that nitrates are supposed to only dilate veins that return to the heart to reduce preload. Well, sodium nitroprusside is a bit different in that it causes both venous and arteriolar dilation, leading to a decrease in both preload and afterload on the heart. Just think of the sailor's red dilated arterial sleeves in combination with his floppy and dilated blue venous pants. There's one little problem with nitroprusside. It's metabolized to cyanide. So we've placed, or misplaced if you will, an extra cyanide exhaust pipe on this gas-powered vessel, dumping cyanide right in his face. Whenever we want to convey nitric oxide gas, it will be a pleasant white-coloured vapour. Cyanide gas, however, is this toxic looking cyan or blue smoke. Especially in the setting of renal impairment or prolonged administration, toxic levels of cyanide can accumulate, leading to lactic acidosis, altered mental status, and seizures. So notice he's looking a bit altered from inhaling so many fumes. We've also added in our recurring sketchy action lines to convey the seizures associated with cyanide toxicity. Alright, the last IV antihypertensive agent we'll cover in this sketch is phenoldiprem, which will be represented, of course, by an old lady named Pam. As she climbs down this emergency rope towards her lifeboat that's waiting for her, there are a few things I want you to notice. First of all, a single rope is our recurring sketchy symbol for the dopamine 1 receptor. Phenoldiprem is a selective dopamine 1 receptor agonist with no effect on alpha or beta receptors. This results in a rise in intracellular cyclic AMP as depicted by the camping tent erected on her lifeboat. Cyclic AMP causes vasodilation in most arterial beds, especially renal, mesenteric, and coronary. Let those loose red dilated sleeves remind you of dilated arterial beds, leading to reduced systemic resistance and afterload on the heart. She must be some kind of royalty, judging by that big dilated coronary crown, which should remind you of phenoldiprem's ability to dilate coronary vasculature. Most important on the exam, however, will probably be phenoldiprem's ability to dilate renal arteries, as depicted by the red arterial rope connecting to the kidney-shaped support at the bottom. In fact, phenoldiprem is the only IV agent that improves renal perfusion while lowering blood pressure. Not only that, stimulation of dopamine receptors in the kidneys leads to increased sodium and water excretion. It looks like she just had enough time to grab a quick salty peanut snack before evacuating, our recurring symbol for sodium. Her hands are a little full, however, with trying to save her own life and all, so the sodium peanuts tumble into the ocean, just like the natriuresis induced by dopamine receptor activation. Alright, that's about all we have time for with our sinking ship and all. Make sure you check out our other sketches covering antihypertensives used for long-term control of hypertension. I don't know about you, but definitely no cruises for me for a while.